Welcome back to the continuation of the Pediatric Sedation Anesthesia course. This is the section 7A, the module 7A, which allows us to go in and investigate the discussion of patient management under sedation procedures. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. This section presents information to create an understanding of the continuum of sedation through which the dentist can make appropriate choices of pharmacologic agents that can be safely and effectively used for various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board of Dental Examiners Rule 110.17, Sedation Anesthesia of Pediatric Patients. Our discussion will be centered on sedation anesthesia management of pediatric patients. The objectives are, upon the completion of this course, you will be able to identify the levels of sedation, manage sedation anesthesia of pediatric patients, and select the appropriate medication. Images used in this presentation are taken from non-copyrighted sources in electronic media and attributed as possible. The identified images are provided as an educational resource to illustrate techniques and procedures for clarity. The goals of sedation in pediatric patient for diagnosis and therapeutic procedures are as follows: to guard the patient's safety and welfare, to minimize physical discomfort and pain, and to control anxiety, minimize psychological trauma, and maximize the potential for amnesia, to modify behavior and or movement so as to allow the safe completion of the procedure, and to return the patient to a state in which discharge from the medical dental supervision is safe, as determined by recognized criteria. Factors that influence the sedation outcome is the selection of the lowest dose possible with the highest therapeutic index for the procedure, selection of the fewest number of drugs, and matching the drugs to the type and goals of the procedure are essential for safe practice. For example, analgesic drugs should be considered for painful procedures such as fractured jaws or teeth extraction. For procedures like x-rays or impressions, sedative or hypnotics are appropriate. If analgesia and sedation is needed, then drugs with that combination of effects are appropriate. The potential for adverse outcomes increases when more than one drug is used. Knowledge of the drug's time of onset, peak response, and duration of action is important. Ensure that drug effect has taken place before adding additional drugs, and know when satisfactory recovery has taken place so that discharge is apropos. Patients who are ASA 1 and 2 may be considered appropriate for minimal, moderate, or deep sedation. Children with ASA 3 and 4, or those with special needs and those with anatomic airway abnormalities, tonsillar hypertrophy, or present with additional consideration, may require consultation with appropriate subspecialties or an anesthesiologist for at-risk patients. Patients with underlying medical conditions, psychological issues, may require physician consultation and or attendance. Do an oral screening to determine airway patency. You need to do the Brodsky or Mallampati exam. Nitrous oxide is a level of sedation considered minimal, and minimal sedation is a minimally depressed level of consciousness produced by a pharmacological method that retains the patient's ability to independently and continuously maintain an airway and respond normally to tactile stimulation and verbal command. Although cognitive function and coordination may be modestly impaired, ventilatory and cardiovascular functions are unaffected. Moderate sedation is a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. No interventions are required to maintain a patent airway, and spontaneous ventilation is adequate. Cardiovascular function is usually maintained. Deep sedation is a drug-induced depression of consciousness during which patients cannot be easily aroused, even by painful stimulation. The ability to independently maintain ventilatory function is often impaired. Patients often require assistance in maintaining a patent airway, and positive pressure ventilation may be required because of depressed spontaneous ventilation or drug-induced depression of neuromuscular function. Cardiovascular function may be impaired. Nitrous oxide provision requirements for all sedation levels prior to use. Nitrous oxide administration requires an educationally qualified by a comprehensive training program consistent with nitrous oxide ADA training guidelines for pain control and sedation, and held at 14 hours duration, including a clinical component by Texas Board of Dental Examiners Rule 110.3. A pre-procedure checklist, a written emergency plan, adequate qualified personnel available for level of sedation, performed and directly supervised continuously. Focused medical evaluation of the patient, signed informed consent, and administered in accordance with TSBDE rules and guidance. Examples of levels of sedation: nitrous oxide oxygen inhalation sedation, the use of nitrous oxide administered for an apprehensive 4 to 5-year-old for axialysis. Minimal sedation is the use of a single drug and nitrous oxide to minimally reduce cognitive awareness and have little effect on the cardiorespiratory systems. An example may be an ASA-1 6-year-old with moderate apprehension using nitrous oxide and hydroxyzine for axialysis. Moderate sedation, level 3 and 2, the use of parenterally administered drug combination of Demerol and midazolam plus nitrous oxide to reduce axialysis, control pain, and amnesia. In deep sedation, which is not the purpose of this training, may be administered as an IV sedation by an anesthesiologist where the patient is not responsive to stimulation immediately, and monitoring of vitals is essential for physiologic management. Responsible person, the pediatric patient, should be accompanied by a responsible adult, legal guardian, or other authorized consented adult. Children who require car seats should have 2 adults for transportation purposes, one to drive, the other to monitor the recovering responsive patient. Facilities that are immediately available with personnel and equipment to manage emergency or rescue situations. The facility should be equipped to handle airway obstruction or complications of the airway resulting in compromised, depressed respiration, hypoventilation, laryngospasm, hypoxemia, and apnea. Hypotension and cardiac arrest may occur, usually from inadequate recognition and treatment of airway compromise. Other rare complications are seizures, vomiting, and allergic reactions. Facilities should be able to provide monitoring and treatment for such complications. Backup emergency services from EMS should be readily available, and until their arrival, the practitioner's responsibility is to provide rescue. Monitors rescue drugs and equipment, and an emergency cart with rescue drugs and equipment must be immediately available with the necessary age and size appropriate equipment, oral and nasal airways, bag valve mask device, laryngeal mask airways, or other supraglottic devices, laryngoscope blades, tracheal tubes, face masks, blood pressure cuffs, and intravenous catheters. The cart must allow for the continuous provision of life support while the patient is being transferred to a medical or dental facility or another area within the facility. All drugs and equipment must be regularly scheduled for checking and maintenance. Monitoring devices such as electrocardiography, pulse oximeters, sized defibrillators with size-appropriate pads, capnographs, and bag valve mask and oral airways of pediatric sizes. This is an example of one type of emergency cart. The drawers are labeled, and within the drawers, in the order of need, are placed in there so that they can be immediately exercised. One can see the need for doing regular scheduled training exercises so that all employees, and especially new employees, are familiar with the concepts of patient rescue. And that means handling of the drugs that are presently on board and maintaining airway and cardiovascular function until the EMS folks arrived. It's important to know where the drugs are, how to administer them, what the drugs' dosages are, and when to give those at what intervals, and to have a recording of the rescue event such that one may refer back to when drugs were given and, if appropriate, what drug dosages were given to be able to handle the rescue appropriately. The preparation of the patient is to review the updated medical history, confirm that no allergies have occurred, and the patient is not taking any medications since the last review of the patient's medical history. If the patient has been in any dental pain, has the patient been taking analgesics, and has it been effective? If antibiotics have been taken, what was the result? 2. The patient has observed the NPO instructions for the sedation, except for seizure and other essential medication, which may be taken with a sip of water. NPO means nothing by mouth on nil per os, solids and formulas 6 hours prior, breast milk and clear liquids 4 hours prior, and clear liquids up to 2 hours prior. The child's caretaker has transportation to return home after the sedation. It is better to have 2 persons accompany the child, one to drive and the other to monitor the position of the child so that slumping with chin to chest is avoided. Consents must be signed by an authorized designee, parent, or caretaker, and often before the day of treatment. Introduction to sedation is important. The child or adolescent is brought to the treatment area dressed in loose, comfortable clothing. The child may be given a calming medication prior to induction of anesthesia, if it is expected that the child may not be cooperative. The parent may be present when the child is being treated in an outpatient setting, during the preparation of the patient, and during early induction for the psychological comfort of both the parent and the child. When nitrous oxide is used, it is started after the monitoring equipment is attached and the child is being receptive to the induction. Once the child begins to appear sleepy, the parent should leave the operatory. This instruction has been previously agreed to. The patient may receive passive protective stabilization previously consented as a safety precaution. If IV sedation, then the child should have the IV inserted when somnolent. Indications for sedation should be considered when traditional methods of behavioral guidance cannot be successful or are not indicated. Careful evaluation of the patient, medical condition, thorough knowledge of the drugs used and their side effects, and clinicians capable of rescue and emergency backup. The maximum recommended dose, MRD, is not exceeded, and the use of immobilization is considered. The traditional methods of behavioral guidance have been utilized. Conditions such as tell, show, do, positive reinforcement, voice control, distraction, redirection, sedation, hospitalization, and utilization of IV sedation are methods to be considered during the behavioral guidance techniques. Once the determination that the behavioral guidance techniques cannot be successful or not indicated is when the advanced techniques of hospitalization, sedation, IV sedation, and utilization of protective stabilization is performed. Any evaluation of the medical conditions that recognizes or identifies a medical condition that may be consequential to the sedation episode is investigated through medical consultation, through evaluation of the patient's abilities to perform, either understanding of what procedures are needed to be done or understanding how they need to proceed during the sedation episode needs to be thoroughly discussed with the parents, and thorough knowledge of the drugs used and their side effects, and do the drugs interfere with each other, or are they additive or supplemental, are they synergistic to be able to use. All of that has to be determined in advance once the patient's known to utilize either IV or PO or IM or intrabony IO treatment modalities. The clinician is capable of rescue and emergency backup, and the trained staff knows exactly what they need to do. Maximum recommended dosages are not exceeded and are calculated in advance, and the use of immobilization is considered, although immobilization does not have to be utilized even though the passive device is present. Moderate sedation is characterized by loss of consciousness, and loss of consciousness is unlikely. We expect the patient to be sedated to the point where they'll be responsive to tactile and verbal stimulation. The patient easily maintains their own airway independently. They have intact cough and gag reflex, and there's minimal effect on the cardiovascular and respiratory systems. This is the goal of moderate sedation. The patients must be an ASA1 or ASA2. This is the American Society of Anesthesiology, and patients 1 are normally healthy without health problem. Patient 2 are a controlled medical condition such as asthma or diabetes or other types of conditions that are not predisposing the patient to being a difficult patient. Patients below the age of reason are indicated for patient selection. The extent of care needed, if lots of care is needed, then more time and doing it all at one time is much more feasible approach than to look at 20 teeth and do one tooth every other week or one tooth every week until the care is completed. It's very difficult for the patient to tolerate that, particularly at a young age of 3 or 4. When the patients get older, they may be able to tolerate that, but it's dependent upon the extent of care, and it's concerning to the clinician to be able to have the patient's attention that full length of time. Fearful or phobic patients are usually adolescent patients who have a needle fear or have some unjustified fearful treatments that have rendered them to be uncomfortable for outpatient procedures, as well as 20% of our children have anxieties and phobias, and it's one of dental treatment is one of the many that are there. Older child with poor coping capabilities, maybe a teenager that's had some difficult experiences and are unable to cope with their own anxieties and emotions. The distance travel, if someone comes from a long distance away It's important to consider the travel time, and is it possible that we may be able to do a sedation and limit the amount of travel that's involved and the time involved of being absent from work and the child absent from school. And those are the cases that we typically take into consideration what is happening. And finally, developmental delays or other handicapping conditions or medical conditions. And when we have those kind of conditions and the patient's at high carries risk, we try to limit the amount of time that the patient has to be present for treatment, and perhaps design treatment priorities in such a way that more treatment can be done at one time for these special patients as they come to see us, particularly if the special patients come from a distance travel. The pre-procedural evaluation is really important. A checklist is important to begin looking at what's necessary to sedate the patient, what some of the evaluations are for tonsillar and airway access are important. And an evaluation of the patient for procedural sedation begins with a thorough history and a careful physical exam that's focused on the review of systems so that everything is understood completely about the health of the patient. Important elements of the history are as follows: the past medical history, especially with respect to previous sedation or anesthesia for dental reasons. The last solid and liquid oral intake is important, and NPO rules need to be followed so as not to activate the GI system in situations where foods eaten and liquids taken will result in nausea and vomiting, which is often a source of stress for both the patient and the clinician. Recent illness, were they having difficulties such as asthma, had a recent asthma attack, had to be hospitalized for a period of day. They have a sensitized respiratory system in an environment where the tonsils may be very large, or they're causing some difficulty for the patient, and the obstruction that might be present. So medication or drug use, what has the patient been taking? Has it been effective? Is it controlling the patient's behavior as well as the patient's symptoms? Allergies or adverse reactions are important to know of that may have developed since the patient was seen initially, and this is to be checked on again at the day of the sedation for the patient. Pertinent family history: has any of the family members been hospitalized or sedated previously, and what were their experiences? Has this something that has occurred within the family as a predisposition? And if so, it needs to be addressed prior to the treatment. Pregnancy status for post-menarchal females. Certainly we want to make sure that occurrence is taken into account when we evaluating them for sedation. Upper respiratory infections, symptoms, cough or cold, or inability to breathe through their nose. A history of reactive airway disease, so we can be sure that when we apply our nitrous oxide, it's going to be effective, and that we do not have enlarged tonsils to be able to proceed. The physical assessment is a general physical condition to see if the patient can walk and talk and understand what's going to happen with them, their cognitive ability at that point. Their vital signs, the heart rate, the respiratory rate, and the blood pressure. Does it fall within the normal realm of vital signs for children of that same age and development? Age and weight of the patients, important to recall, so that these patients are of an age and weight with expectations for their behavior and their acceptance of the sedation episode are determined. Airway clearance with the tonsils, nose, and tongue. The tonsils should be in a level of in a condition that allows intubation should it be necessary. The nose is clear and unobstructed, and the tongue is of average size and not obtunding the opportunities for ventilation. Mouth breather, if you have one of those, it can be a result of a patient who has some airway obstruction and they're breathing through their mouth as a manner of getting the oxygen they require. C-spine positions and abnormalities. Can the patient's head be hyperextended? Is that necessary to do that? Is there any atlantoaxial instability, usually with the trisomy 21 patients, to make sure that they can have their head elevated appropriately for access if intubation is needed? And the patient has nasal speech, which generally means adenoidal tissue or tonsillar tissue is leaving them to talk through their nose. And that's an important feature to know because it causes mouth breathing. Mid-face hypoplasia, congenital defects of patients who do not have good facial development may compromise their airways, and so it's important to know that in advance. Obesity are patients who exceed the 95th percentile for their age and weight. If it becomes heavy between the 85th and the 94th percentile, these patients need to be observed and maybe talk to them about dietary guidance. And finally, communication ability. Do they understand what is going on? Are they nonverbal? It's important to know if they have that condition so that signing or a person who does sign can come in and help out, or utilization of pad and paper to provide information to each other. Sedation routes are inhalation. Nitrous oxide, for example, is an inhalation drug that's utilized when patients undergo general anesthesia. Inhalation is a very important ability to do that, so as the drugs used for general anesthesia is accompanied by support with oxygen and nitrous oxide, and those are important things, as well as sevoflurane to be able to inhale properly. Oral administration of midazolam, demerol, hydroxyzine, and diazepam are drugs that can be given orally, so that's a nice route to be able to use, and it's much more acceptable to patients than using intranasal, intraosseous, or IM or IV sedation. Intranasal is used for drugs like Versed, which are quickly absorbed through the nasal mucosa and omits the bypass to the liver, the first pass to the liver, and allows patients to have intranasal application of their medication. IM, Versed, Demerol, and hydroxyzine can be given IM, and Demerol and hydroxyzine, for example, and Versed, for example, can all be intermixed when you give the medication. IV can be using Versed, fentanyl, propofol, and ketamine. Many of those drugs, other than Versed, are drugs that are used by anesthesiologists that come to the dental office and provide that service. Having a sedation record is really important, and this is a sedation record that was developed by the American Academy of Pediatric Dentistry, and it's very self-explanatory. However, we do want to take a look at this and see exactly what is really important. First of all, we need to know the patient's name and sex and age in years and months, in weight by kilos, and the date and the physician who looked at the patient, and look at the indications for sedation. If a patient comes to your office and they have a dental toothache and is simply on one tooth, is it better to take them to the hospital and put them into sedation and do that? It would be if the patient were fearful, if the tooth was very severely decayed and perhaps needed to be extracted. But justification for taking the patients to the hospital is really important to annotate, because it justifies the reason that the patient is going to the hospital. Fearful patients or patients unable to tolerate outpatient procedures. Some patients may cause developing issues with their developing psyche, and what patients' medical risk that they have. Then looking through the medical conditions, it allows us to understand what sort of medical complications may be associated with that, and a description of the positive findings that we have there, and the airway assessment. Is the patient obese? Do they have a difficult time? And if they did, you'd say yes. And then they have some neck immobilities, and if they have that, that's going to compromise macroglossia, micronasia, tonsillar obstruction, and limited oral opening. All of those features need to be added to the justification for taking the patient to the operating room, and then a declaration of what ASA category they fall into, and medical consultations indicated if we have any questions about those medical procedures. And then finally some comments about the patient. Does the patient perform a candidate for in-office sedation, yes or no? Then the dentist's signature and the date. And once we know that information, we are well justified in taking the patient to the operating room. Putting the plan down onto the patient's record is important to do. Have we done informed consent? Do we have the proper person agreeing to the treatment of the patient? Have we given preoperative instructions, and have we given preoperative precautions explained with whatever person that is and initials of that patient and the date and by whom was this information gathered? The assessment on the day of sedation. This is when the patient comes in for the actual sedation episode, and they're accompanied by who, and the relationship is the father, the mother, grandmother, authorized individual, and the date. And then there's a quick updated medical history and review of systems. Has there been any change in the medications the patient is taking, and the respiratory illness, the weight of the patient? Have you taken anything by mouth, clear liquids, what they might be, and assessing that. And then the airway, upper airway is clear, lungs are clear, and tonsil characteristics and what percentage they have, the appropriate home instructions and monitoring facilities and emergency kit available. Do we have all the things that we need to make sure that the patient can be resuscitated? Vital signs, blood pressure, respiratory rate, pulse, temperature, and oxygen saturation. And these days we are using capnography to detect the exhaled CO2 levels, which is a much quicker, more reliable reason. When we talk about monitors, we'll be talking about that. And the procedures that we expect to do for the patient is unable or willing to cooperate, the reason that we followed up with them. So those are the things that we need to know for our sedation plan. Then calculating the drug dosages on the day the patient comes. Let's say we have Demerol, Vistaril, and chloral hydrate or glycopyrrolate. The route we're going to use, IV, oral, PO, or IM. And then by the kilograms, we're calculating their dosage level, plus or minus the behavior of the child. And then looking up the milligrams per milliliter and establishing the correct dose, which is listed out here on the final line. Reversal agents are calculated in a similar manner and put out here for us to determine exactly how much that we want to give to the patient. And finally, the selection of the local anesthetic is calculated based upon these dosage numbers, and it's brought over here and it's determined by Coppuel how much that we're going to give to the patient. So this is all determined in advance, and it allows us to treat the patient. Once the patient is begun with the sedation, the agents that are used, and the route, and how we place that, how is it affecting the patient? We've got some sedation levels here. We've got some behavioral responses that we add up here on these lower lines to tell us how the patient responded to the medications that we have given to the patient, and recording the O2 saturation, the pulse, blood pressure, respiration, and CO2 is important for us to get on here over a timeline of no greater than 10 minutes with each recording. And it's important for us to know that so that if we have subsequent sedations, we'll know exactly how much to give to the patient. Finally, when the patient is finished with their procedure and they're ready for discharge, it's important for us to look at criteria for discharge. That is, the patient function is satisfactory and stable, the airway is open and satisfactory. The patient is easily arousable, and they have responsiveness as appropriate, and all the information that's protective reflexes are intact and can sit up unaided, and they can have a conversation with you. And then we take their discharge vital signs before they leave. It's important. And the discharge process, the postoperative instructions are reviewed with the parent, and they're written and verbal. Some information to do that, and how the patient's activity was, the diet, nausea and vomiting, anything that occurred, fever, emergency contact number, and then a place for the signature of the parent and the relationship, and after hours number to get in contact with them. And then the operator signs, the chairside assistant, and the monitoring person is indicated right there. The postoperative call is indicated here for a call. The patient on that same day was called at 6 o'clock in the evening, Susie Smith, and spoke to the mother, and the comments are that the patient was doing fine, was recovering great, and that the patient was eating as instructed, and clear liquids for that evening or soft diet for a patient for the next day. And then a postoperative call is given to the patient at another time. So those are important parts of the sedation record that are absolutely necessary to administer so that we know what is the effect of the medications we use. The medication, once we give them, may be given by mouth, intramuscular, IV, intraosseous, or intranasal, and the selection of the proper method depends on the ability of the child to tolerate taking medicines. Some children, some younger children, don't like medications and they will spit it out, and that should be elicited by asking about the medical history, about medical immunization. Reluctant children should be administered the easiest method to avoid conflict. Sometimes that means we'll give intramuscular sedation, sometimes intranasal sedation, but we want the patient to be calmed as much as possible so that we can go ahead and move forward with the treatment. The use of nitrous oxide. This is a patient who's receiving nitrous oxide. These are masks that are flavored masks that are used in conjunction with an extraction method of waste anesthetic gases, and this is the safest thing for the operatories where everybody's working. And you really want the child to be very cooperative when they're using nitrous oxide. And this is how it looks when a child is being cooperative. They're opening their mouth really wide, being able to help as much as possible. Here's a patient who's receiving some oral medication, and this patient is in particular receiving some oral medication. And this is what happens when we give medication. And the choices are here in these situations is either to provide oral medication or take the patient to the hospital if they have an urgent situation that has developed. Because this child in particular is uncooperative for a dental exam, and it's important for us to move on to try and help that child in spite of their behavior. This is the oxygen desaturation curve, which we've talked about before when the pH goes down, and the DPG, which is phosphoglycerate, and the temperature increases, and then the curve moves to the right, and there's less oxygen saturation than before. And if the pH goes up, the DPG goes down, and the temperature goes down, then this curve moves to the left. And we're within 4 millimeters of mercury based upon this line because of the dead space that's in the patient. What we really need to focus on is what happens when this curve starts to take a downturn. We look here very carefully, is at 90%, and we're at the beginning of the curve, and then once the curve starts going down very quickly, it hits a very rapid slope of departure. Oxygen saturation descends very quickly, and we have mentioned already that the patient's residual oxygen level is very low because of the immature respiratory system. Now, what about conscious sedation of pediatric dental patients? There have been some studies which help to determine what the dosage is, and an investigation of chloral hydrate, hydroxyzine, and meperidine versus chloral hydrate and hydroxyzine by itself the addition of meperidine. And what has it done for this patient? This was a study out of North Carolina, and it was done back in 1991, some time ago, and it compared chlorohydrate and hydroxyzine with and without Demerol 1.5. And what they found out is following oral administration, the analgesic effect are detectable within about 15 minutes, reaching a peak of about 2 hours and subsides gradually over several hours. So not only does it sedate the patient, but it provides an elevation of the pain threshold. Approximately 50% of the oral dose survives first-pass metabolism and is available systemically. Meperidine is metabolized chiefly in the liver, and it's important that no liver issues are present. The recommended oral dose of meperidine for sedation has been derived empirically, and varies according to the source. And most agree on a dosage range from 1.1 to 2.2 milligrams per kilo. Moore and Goodson in 1985, Goodman and Gilman in 1986 and 89 have agreed with this dosage level. So this is something we need to be cognitive of and make sure that the patient is receiving the proper dosage for themselves. Dose-responsive characteristics of meperidine in preschool children was done again by Dr. McKee, Dr. Nassif, and Dr. Jackson, Barnhart, Close, Moore, Pediatric Dentistry in 1990, again an older version, and they compared Demerol at 1.5 milligrams per pound with 0.5 milligrams per pound intramuscularly. And what they found out that meperidine administered 1.0 milligrams per pound was associated with a significant increase in nausea and vomiting when compared to lower doses of the drug. So the highest dose was 1 milligram per pound of meperidine, would provide sedation rating that are significantly higher than 0.5 milligrams, and this must justify the combined use of an antiemetic such as promethazine or hydroxyzine with meperidine, because it's additive and it allows us to sedate the child with lesser nausea and vomiting that might occur in these patients. So it's a good combination and is still in use today. Here's a chart which shows from the project USAP in 2000 the use of sedative agents by pediatric dentists, a 15-year follow-up survey by Dr. Haupt out of New Jersey. And the conclusions that he showed is that he found the dose that worked for hydroxyzine and nitrous oxide, the number of individuals that were given this dosage, and the percentage of patients who took that dosage level, and arrived at a consensus for us to apply a proper dose of midazolam, diazepam, meperidine, chlorohydrate, promethazine, hydroxyzine, and nitrous oxide with that, although at this point chlorohydrate is no longer on the market. So a good use of our drug dosages to make sure the patient's receiving the proper dosage. Newer drugs in the professional arena are fentanyl, which is an IV drug generally administered by anesthesiologists, and dosages for children that are less than 6 years of age is 0.3 to 1.5 micrograms per kilogram dose by slow IV push over 1 to 2 minutes and repeated at every 1 to 2 hours. If they're greater than 6, then you have a greater dosage, 1 to 5 micrograms per kilogram dose by slow IV push, repeated 1 to 2 hours. The dose may range from 1 to 10 micrograms per kilogram per dose. This is generally a very utilized drug for IV sedations, and many dental offices these days are employing anesthesiologists to come in and deliver the IV sedation for their patients and avoid going to the hospital, which has the added facility cost. Drug interactions. What happens when we have a drug that comes to the body? Well, pharmacodynamic aspect of a drug is what the drug does to the body. The pharmacokinetic aspect is what the body does to the drug. And any drug that can stimulate the gamma-aminobutyric acid GABA receptor in the CNS can cause axial-lysis or sedation. Threshold amounts elicit responses. Drug doses are based upon averages, and those were some of the preliminary investigations in the 90s and early 2000, individual differences such as genetics, gender, age, organ function, and internal bodily environment, plus other medications affect the outcome of delivered medication. And this was determined by Trincavelli, Dipozo, Danielle, Martini, and the complex as a target for the development of anxiolytic drugs. So we know what that has been. And what was discovered is that benzodiazepine, drugs like diazepam, augments the naturally occurring neurotransmitter GABA, and the benzos are characterized as agonists that bind to the receptor site. The antagonist drug is one that will block a reverse agonist-mediated responses and has no efficacy itself. For example, diphenhydramine is the agonist drug, and histamine is the effect that we're trying to get. Naloxone is a reversal drug for opioids. Flumazenol is a reversal drug for the benzodiazepine. So it's important to know that these drugs are contrary to each other, and one is a drug dosage for sedation, and one is a drug that will be a reversal agent. And here we have the dosages available for those drugs. Naloxone or Narcan is 0.4 milligrams per ml. Flumazenil or Romazicon, R-O-M-A-Z-I-C-O-N, Flumazenil, Romazicon is the brand name, is 0.1 milligrams per milliliter. Epinephrine, 1 to 1,000. This is a drug that we commonly use when we have a anaphylactic reaction and we do an intramuscular injection, and so we need a more concentrated drug that we can administer intramuscularly. Diphenhydramine, we offer that as well to our patients, 50 milligrams per milliliter, and we typically follow up with 25 milligrams of diphenhydramine as a empirical dose when a patient has a anaphylactic reaction. Phentolamine is a drug that reverses the action of local anesthetics, and it comes in these cartridges. And atropine tends to elevate the heart rate in a patient who may be a little bit bradycardic, and so we can use that for reversing bradycardia due to the bradycardic effect of the medications that we give to our patients for sedation. Naloxone has 1 milligram, 1/10 of a milligram per kilo, and can be administered IV, IM, sub-Q, or endotracheally every 2 to 3 minutes until response. And we know we have learned by this that we generally give 2 milligrams right at the outset for our patients, and it has a half-life of 1 to 2 hours. If the child over 5 or weighing greater than 20 kilos, the dosage is 2 milligrams every 2 to 3 minutes until we get a response. Flumazenil is an antagonist for the benzodiazepine, administered IV up to 1 milligram over 1 to 3 minutes, and it's 0.01 milligrams per kilo for children. IM, sub-Q, sublingual, can reverse CNS depression, has a duration of action of up to 1.5 hours about. It's used to reverse deeper sedation than intended, monitor the patient for at least 2 hours afterward, and it's an important drug to use if we suspect that we're having some difficulty with our respiration. Epinephrine, a drug that we use commonly in an anaphylactic reaction, and 0.2 of a milligram per kilo IM, and the children's 0.01 milligrams per kilogram of 1 to 1,000 every 15 minutes to a maximum of 0.3 for a patient weighing greater than 30 kilos, or 0.15 milligrams for kids 10 to 30 kilos. Epi causes bronchodilation and increased vascular resistance. As the heart rate increases and the blood pressure increases, cardiac contractility and myocardial improvement and cerebral blood flow. It has an antihistaminic physiologic effect. So we carry this epinephrine in all our emergency kits. Diphenhydramine competitively blocks H1 histaminic sites and causes contraction of GI and bronchial smooth muscles, 1 to 2 milligrams per kilo, IM, IV, IO every 4 to 6 hours to a maximum 50 milligrams. It's metabolized by the liver and excreted by the urine. It has a half-life of 2 to 8 hours, causes patients to be drowsy, reduces nausea and vomiting, and local anesthetic activity. Phentolamine, you remember, reverses the local anesthetic effect, and atropine elevates the heart rate. Phentolamine reverses local anesthetic. Atropine doses of 0.02 milligrams per kilo with a minimum dose of 0.1. So it's 5 times this dosage level. May repeat once to the maxillary dose of 1 milligram and a maxillary dose of adolescent for 3 milligrams. IM or IV reverses clinically. Significant bradycardia is defined as heart rate of equal to or less than 60, has a half-life of 2 to 3 hours. Oral midazolam is a great drug that's being used these days for very short procedures. The beauty of this drug is that it has anterior grade amnesia. So this anterior grade amnesia that allows the patient to receive care, but they do not remember anything that happened. They did an evaluation of 2 doses of oral midazolam as a conscious sedation agent for physically and neurologically compromised pediatric dental patients, Dr. Silver and Dr. Wilson, Dr. Webb, pediatric dentistry, and this was in 1994, back when we were empirically discovering proper dosages. And the volume of Group A, which was 0.3, versus Group B, 0.5, on special patients. The overall success is determined by this ability to complete treatment with 75% for Group A, that's the 0.3 milligram group, and 60% for Group B, which is the 0.5 milligrams per kilo. The results indicate a slight difference in effectiveness of the 2 dosages, and in general, the patients were more cooperative and less combative with the lower dose. So that would suggest that 0.3 milligrams per kilogram is an optimal dose for using oral midazolam, and also it's a decreased dose for the 0.5 milligrams, which is typically used for oral midazolam alone. So if you use this with hydroxyzine, would be a good combination to do. It appeared that the children with a more rapid onset received less distraction and stimulation, eliminating factors that might produce apprehension and allowing the child to relax. So good things to use. Here are some of the results of that study. And this is good to notice when you're looking here, we're looking at diastolic blood pressure. And when you look at Group A, that's the 0.3 milligrams per kilo, versus Group B, which is this solid line up in here, what you do see is that Group B, which is a higher dosage, has at the 20-minute point a higher level of diastolic blood pressure than Group A, which is 0.3 milligrams per kilogram. And we would really like to have our blood pressure somewhat under control, although it doesn't look like it's that much higher in terms of we're going from, this looks like it's about 70 meters of mercury, and this is probably 77 or 78 up here. So not a great deal of difference. Not statistically significant. And we had a drop at the 50-minute level that the diastolic blood pressure dropped in here at this point. So important to remember, here's the systolic and the pulse rates. Again, here's the higher dose, having the peak at, again, 20 minutes, and then over here a drop at 60 minutes. Here is the pulse rate. The pulse rate tends to be going up higher. So that may be the advice that we receive over here. As the blood pressure goes down, the pulse rate goes up to compensate for that. So that's the effect of the midazolam that we're seeing here. And then finally, oxygen saturation. Remember, heart rate goes up, blood pressure goes up, and the oxygen saturation also going up here because of the increase in the heart rate of this patient. So characteristics of the midazolam: it's water soluble in its acid formulation, but it's highly lipid soluble in vivo, which accounts for its bad taste for oral use and rebound effects when reversed. Midazolam also has a relatively rapid onset of action and high metabolic clearance when compared with the other benzos. Like lorazepam, for example, is a benzo. It has a longer clearance period of time. That's why it's not used in dentistry, because it's up to a couple of hours to have it recover, whereas this recovers in a short period of time. The drug produces reliable hypnosis, anterograde amnesia, anti-anxiety effects when administered orally, intramuscularly, or intravenously. Midazolam has a habit, though it remains with the patient for a little bit longer than we'd like, and so when the patient begins to recover and wants to go home, we have to warn them that they may stumble over some speed bumps in the carpet when recovering, when ambulation begins to occur. And it's seen very typically with midazolam when they begin to ambulate. They tend to be a little bit uncoordinated. Personal interactions were noted prior to sedation. Children who were extroverted tend to be more successful sedations than those who were timid or introverted or shy that did not relate well with others. These children were difficult to sedate and even more difficult to make patients cooperate. And this is quite true for shy patients who like to hide behind their mothers, and they tend to have very poor social skills, and they're much more difficult to handle. So having a good relationship and an interaction with these patients is really important to establish a good rapport and get them to cooperate for you. Opioids increase activity at one or more G-protein coupled transmembrane molecules known as the mu delta kappa and opioid receptors. The receptors are widely distributed throughout the human body, and those in the anterior and ventrolateral thalamus, the amygdala, and the dorsal root ganglia mediate nociception. And nociception is the perception of impending things that are not good for you. And the amygdala is also the one that recognizes impending bad things in the central nervous system. So the mu-opioid receptor is responsible for the preponderance of clinical effects caused by opioids. A respiratory rate of 12 breaths per minute or less in a patient who is not in physiologic sleep strongly suggests acute opioid intoxication, particularly when accompanied by meiosis and stupor. So when you look at the cognitive central nervous system activity level, if the patient is kind of in a stupor and has these constriction of the eyes, then you have a patient who has decreased number of breaths, and it's important maybe to think at this point about getting some opioid reversal agent ready to reverse this myopic and stupor, because these patients, you want them to go home. Demerol, on the other hand, is an opioid, and it has sedation, euphoric effects, which are great for you because they tend to be happier. Then if they have an antagonistic paradoxical reaction, they have dysphoria. And that means that the Demerol, even though it's on board and should create a patient who is happy, have this dysphoric effect, some delirium, agitation, anxiety, disorientation, drowsiness, lethargy, impaired mental and physical performance, and mood changes, weakness, headache, tremor, convulsions, meiosis, suppression of cough reflex. Some of these are good effects like the euphoria and the pain control, sedation, but some of the other aspects of the utilization of Demerol are not good side effects, and so it's important to really think about, is that the drug that you want to use, or maybe finding a drug like midazolam that will handle short-term procedures to do and be much more favorable. And adding to this the hydroxyzine to help control the nausea and vomiting, dry mouth, anorexia, constipation, spasm. So adding these two drugs together is really important. Facial flushing, peripheral circulatory collapse, tachycardia, elevated heart rate, bradycardia, low rate, arrhythmia, palpitation, chest wall rigidity, that was a feature we mentioned before, hypertension or hypotension, so the blood pressure goes up and down, orthostatic hypotension, if your patient's been laying down for a long period of time, you want to make sure that you sit them up while they're recovering with a nitrous oxide on their face with 100% oxygen. Syncope, fainting, urethral spasm, urinary retention or hesitancy, oliguria, antidiuretic effect. So these are important things. You want to make sure that your patient's hydrated before they come. They're taking those clear liquids up to 2 hours prior. If you develop pruritus and urticaria, laryngospasm, bronchospasm, edema, then you can handle these issues here with the utilization of Benadryl, to give them a dosage of Benadryl to clear up this area if this occurs. And if you have this in association with some unavoidable sedation effects of the patient, you may be thinking of, is this patient going into an allergic reaction? And if they have this, along with the symptoms of emergent anaphylactic reaction, you want to be sure you have your diphenhydramine along. Major hazards are respiratory depression, apnea, circulatory depression, respiratory arrest, shock, cardiac arrest. So those are major hazards, but usually preceded by the phoria and the respiratory depression that's going on. You see these start off, and then you end up with your cardiovascular being involved, sweating, physical tolerance, and dependence. So the key to using Demerol is recognizing when patients have a difficulty with their respirations, and the patient may initially have some respiratory depression, and it's going to go to apnea, circulatory depression, respiratory arrest, shock, and cardiac arrest. So this is the area you want to avoid. So making sure that you're supporting the respiration as much as possible, as clearly as possible, as your patient begins to deteriorate and go into deep level of sedation. Opioid overdose in patients with severe respiratory depression, restoration of ventilation and oxygen, takes precedence over obtaining the history of the present illness or performing a physical exam. So ventilation and oxygenation, really important before you issue an opioid dose, because it becomes very quickly overly activated and can cause the respiratory depression, leading to those cardiovascular effects we just spoke of. Ventilation should be provided with a bag valve mask, chin lift, and jaw thrust. And that can be accomplished by pushing with your index fingers on the angle of the mandible, moving the jaw forward, and this jaw thrust maneuver should be ensured to ensure that anatomical positioning helps to diminish hypercapnia. If you're looking at your hypercapnia and you see the elevation of your CO2 levels and your numbers start to increase, you want to get more ventilation occurring, and you can do that by ensuring that the patient has a jaw thrust, and you perhaps have to go to providing adequate ventilation that offers a certain benefits for restoring oxygen. And you do that with a bag valve mask and preventing the postulated sympathetic surge that triggers pulmonary edema after reversal of apnea with minimal risk. So you start to see minimal risk when the patient's breathing shallowly and when they act with a stupor and their eyes are myotic. Once you start to see that, you want to go to a jaw thrust maneuver, and that jaw thrust maneuver will help you to get the patient oxygenated with your bag valve mask and improving your situation and diminish the hypercarbia and improving the oxygen saturation level that you need to do. If the patient continues to get worse, it's the time to call for your 1 to 1,000 epinephrine. Be able to make sure that's on board. And also naloxone, your antidote for opioid overdose, onset of action is less than 2 minutes. Remember, add 2 milligrams with this patient. That's about a 5. You get those 0.4 milligrams per milliliter. And so you do that 5 times from those ampules, and you'll have the patient at 2 milligrams when they need to do that. And if you have access intravenously, be easier to give that. Its apparent duration is 20 to 90 minutes. So you need to have the patients present with you for a longer period of time, because the shorter period, you're not going to be able to overcome the respiratory depression that's partially there from what you're doing. So for the initial dose of naloxone for adults is 0.4 milligrams per. And if there's no response, the dose should be increased every 2 minutes according to the schedule to a maximum of 15 milligrams. Once the respiratory rate improves, then patient can be reserved for 4 to 6 hours before discharge is considered. Children that are 3 years or younger, been exposed to opioid analgesics, should be admitted for a 24-hour observation period, 24-hour. So if you have a child younger than 3 or younger, you want to admit them to the hospital for observation. And these initial doses should be 0.1 milligrams per kilo or 2 milligrams rescue dose. So it's important to know exactly when to act with these. We have some rescue cards available from the American Academy of Pediatric Dentistry, and this is a protocol that uses a child dose over here and an adult dose over here, and that the dosage amounts are increased significantly at each level. This is the 2 milligram dose that's advised, and then here is a 4 milligram dose. Here is a larger dose, even up to 15 milligrams here. So follow those diagrams, follow those dosages, and we know about the mechanism of action. We're trying to reduce this when we give an antagonist so that it removes that from those positions. Hydroxyzine is classified as a long-acting, 6 to 24 hours antihistamine, weak anxiolytic. It acts as a central nervous system depressant, and is also used as a tranquilizer. Has been preferred in combination with opioids due to its ability to counteract the side effects of itchiness and nausea, and its sedative properties complement the pain-relieving aspects of the opioids. Diazepam is a benzo, and it alters the brain function to produce a calming effect. It's usually used for teenagers that have not been satisfactorily sedated because they have anxiety. It treats alcohol withdrawal and muscle spasm. It's a longer acting than midazolam. May be administered orally, intramuscularly. When given IV, begins in 1 to 5 minutes and lasts up to an hour. By mouth effects may take 40 minutes to begin. It's useful for children greater than 50 pounds. So if you've exceeded your dose of Demerol, your opioid for Demerol and its concomitant drug hydroxyzine, then this is a drug that you may want to go for these children that are older that have these anxieties about needle phobia, etc. So that is an overview of the drugs that we use for sedating patients. You have a fairly wide choice. Midazolam happens to be one of the most common ones for short procedures, and Demerol and Vistaril happen to be the drug combination for at least an hour to an hour and 15-20 minutes that will help. There are some drugs like diazepam that can be used for older adults, patients with physical disabilities. That's a milder one, but longer acting. And so if you need any clarification on these drugs, send an email to the PACE for us to look at, and we'll be happy to answer any responses that you might have. So at pace@uth.tmc.edu. And then these are the references where you can go and look and read up some articles. Some of the studies that we talked about here are in here for the management of children with their drug management. So it's there and available for you to look at and see if you need to have further information. This completes this section 7A of the course. It's time for you to take a short exam in order to complete the requirements for streaming video courses. And once you have completed that, the nature of the subject, you need to get a passing score of 80%. It's necessary in order for you to advance to the next section. Upon a successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam, and a new set of questions will be provided. You'll have 3 chances to fulfill the requirements. If you're not successful, you'll be instructed to review this section again. Good luck on the exam. If you're ready to take it, the next section, upon the completion of the exam, you'll be provided a link to continue. If you wish to proceed at a later date, you will need to log in, and no further payment is necessary since this is a continuum.